Hi, I'm Priya Nanda, a public health researcher working with the Bill and Melinda Gates Foundation. My leadership project is about contextualizing grounded measures and pathways of women's leadership in the health sector. The leadership journey has been about my own reflections of my leadership and about leadership experiences of women nurses in the health system. My own journey has been one of self interrogation. It's about the contradictions of accomplishment and self efficacy, and yet self doubt and diffidence. A journey where I realize, unlike women in my peer group, many women at the front lines of health system do not get opportunities to think about their leadership nor have words to describe it. I chose a purposive sample of nurses trained by two different organizations, Basic Health Services in Udaipur and Ekam Foundation in Tamil Nadu, to explore what leadership means for their context. How do they understand their own leadership? I explored local definitions and descriptors of leadership, partly also to challenge a status quo understanding of leadership that may be coming from more male dominated or hierarchical systems of management. My curiosity began with the work that I've been shaping in terms of my investments at the foundation with colleagues from Oxford Policy Management on reviewing gender unequal practices within the health system, of which leadership is a critical domain. We find a deficit in women's leadership. It's one of the most critical underpinnings of several gender issues faced by women in the health workforce, including that of poor working conditions, vulnerability to workplace violence and sexual harassment, gender pay gap, and lack of adequate resources and representation of women in the leadership position that precludes them from participating in policies and decisions that have a say in matters that affect their profession. The determinants of leadership deficit, if we look at frameworks, they span from access to assets and resources, the everyday practices and participation, norms and values and beliefs within the health system, within facilities, and then overall laws and institutions and policies. What's interesting here is the everyday practices of high work burden, punitive accountability, um, coupled with norms that around what are gender biased stereotypes of women and men's role in facilities create very entrenched ways in which women's leadership cannot be recognized or emerge, and then coupled also with poor resources as and opportunities for training and representation, and laws and policies that support overall growth and advancement. So, moving to what I actually found through my field work, which is just about starting, I would say, that all the nurses that I interviewed, they're strong, competent nurses who play important roles in coordinating, managing, delivering quality health services in the communities they serve, and are aware of that. They're not shy to admit that they do their work well and that they work with integrity and honesty. They have repeated training to get to where they are, uh, but each one has a story of persuasion or perseverance, even before they came to BHS or ACOM, around how they struggled to get their higher education to be qualified as nurses. Once they come to these organizations, they receive repeated training and get respect and confidence to do their work, and even tasks beyond what they're initially trained for. So these nurses are, I would consider, a specialized group because of the kind of support they're getting from these organizations to be more confident. Um, while it's not easy to relate to them to the idea of leadership, on probing, they do dwell on their leadership qualities that span working with honesty and integrity, bringing others along, mentoring, closing the loop in terms of their work, seeking advice, going beyond the parameters of their job at times to help others and take on challenging cases and even help manage them well. Despite such everyday heroic acts, what struck me was how gendered their own construction of leadership was for themselves. They're shy, self effacing, and hesitant. They lacked vocabulary to define their own leadership qualities. This was probed several times, which did lead to interesting conversations around how each of them had taken on initiative, demonstrated a can do attitude to the most challenging situations, sought advice, created mechanisms for de-bottlenecking, and networked to link to external resources to help people in distress outside of the purview of their current role. And yet, they lack in describing themselves as leader. An example, Najma, her name has been changed, is a coordinator and knows she's very capable and talented in her work, but hesitates to talk about her talent as a leader, relegating it qualities like working with honesty, speaking well to others, bringing others along rather than alienating them, being adept at her work. On much probing whether she considers herself a leader and comparing herself to the male nurse whose leadership is manifest as he speaks to others with authority, which she doesn't, she said, yes, she is a leader in her work, but she does not believe in talking with authority as she is strategic and wants to make sure she brings everyone along, and it's important to do that to do good work. Shyness and diffidence is evident in comparison with male nurses who tend to assume proxy roles for medical officers. They get accorded that status by the community and they have no difficulty assuming this role. Women nurses cannot take on those roles for doctors in absentia. They censor themselves, and neither are they given that status by the community. So gender roles and stereotypes really persist even in when women are equally well trained as male nurses in the community. I'm still working on this data, the analysis, and trying to better understand what are what would be attributes of a gender responsive leadership system within the for women in the health system. So this is just work in progress. What I intend to do is to design a large survey, perhaps mounted through the Indian Council of Nurses, where I want to explore key indicators both at the individual level as well as at the organizational level to really understand what facilitates women's leadership, and also to ground more contextual definitions of women's leadership as even has emerged in the small exploration that I have shared today. So as I end, I just want to say that I'm really grateful to WomenLift to have brought such an amazing leadership journey to us. It's given me a peer group that is fantastic and supportive. It's given me an understanding of how similar our experiences are and how we have tended to censor our own leadership potential. It's made me realize the power of peer networks, and that learning negotiation skill is also about the art of influence. And in order to achieve what we believe in, we must learn to influence effectively. Thank you with great gratitude to Basic Health Services and to Sanjana, who's also a cohort member, for helping me facilitate meeting with the nurses at PHS. And to Helen at Ecom Foundation, who I haven't met but only spoke to her virtually and on phone. Thank you.